All right. Well, let's go ahead and get started. Thank you, everyone, for joining during this summer session. Just to kick us off, this is a joint symposium that includes sponsorship from the KP Aim High Initiative, Augmented Intelligence in Medicine and Healthcare, as well as the Health AI Partnership. And we're looking at real-world cases of AI deployment. And today we're joined by a really exciting example of AI in the real world. That includes our guest speaker, Demilade Adedinsewo. Sorry, I'm just trying to read that correctly. Who's an assistant professor of medicine and non-invasive cardiology at Mayo Clinic in Florida with a clinical focus in women's heart health and echocardiography. Her research focuses on heart disease in women and the use of digital technologies and AI to improve cardiovascular care and enhance health equity. She's currently a Mayo Clinic Women's Health Scholar and works closely with the Digital Innovation Lab at Mayo Clinic in developing and evaluating ECG-based AI algorithms. And we're also joined by David O. Yang as our discussant, who's a research scientist at the KP Northern California Division of Research, a non-invasive cardiologist and echocardiographer at KP Santa Clara Medical Center. His group works on applications of deep learning, computer vision, and statistical analysis of large data sets within cardiovascular medicine, with his work having been published in Nature, Nature Medicine, New England Journal AI, Circulation, JACC, and a number of other prominent journals. And he's also the deputy editor for the New England Journal of Medicine AI. So just before we jump in, we'll be having Demilade present first, and then we'll leave time for David to take us through some discussion points and comments. And then we will open it up for a question and answer and discussion session. So if you wouldn't mind going ahead and putting your questions into the chat and then raising your hand once we get to that stage, I'll try to help moderate that process. Okay, so without further ado, I'm going to turn it over to Dr. Adedinsewo.
Thank you so much, Vincent. I'm going to go ahead and try to share my screen. So I think I can replace what you have. Okay. Let's see. It's always hard to tell if you're seeing the correct screen, so hopefully you are, and then I'll just go ahead and get started. So thank you so much for the invitation. Thanks, David. I'll just go ahead and start because the topic has already been introduced. So I won't spend too much time on that, especially because we have roughly about 30 minutes for this presentation, and I want to leave time for questions at the end as well. So I'll get started. So I just wanted to mention that specifically for me, I do have some disclosures. It's all research grants. I do have funding right now from the Mayo Clinic Women's Health Center, Miami Heart Research Institute, and the trial originally was funded by Mayo Clinic with some support from NIH funding as well. Otherwise, no other relevant disclosures. So for me to tell this story, I know that the goal of this session is to talk about, real world example as well as implementation of this AI algorithm. I wanted to kind of give you the background and rationale. Why did we decide to do this study in the first place, and how did we get to the point of implementing it in the context of a clinical trial? So just some background on epidemiology. Maternal morbidity and mortality in the US is something that has become a topic of concern over the last couple of years. Over the last 3 decades, a lot of epidemiologic studies are showing that maternal mortality rates have actually been increasing. And there's also a significant disparity in who dies during pregnancy, as well as within 12 months postpartum. We see that mortality rates are 3 times higher for Black women in the United States compared to white women. And there's been several attempts at trying to understand the reason for maternal mortality. And there are these committees that have been put together across multiple states, morbidity and mortality review committees. And their assessment was that up to 80% of these deaths are actually preventable. So I wanted to show this slide. This is from a paper that was published in 2015 from the Global Burden of Disease Study, just showing U.S. maternal mortality and comparing it to other high-income countries. And you can see that the United States is an outlier. Now, this is U.S. specific data, just showing maternal mortality and broken down by race and ethnicity. And you can see that the rates are much higher among Black women. And this is also showing the trends over time. So through 2021, we were seeing an increase in maternal mortality, and 2022 data, which was recently published, is what we have as the most recently available data, is showing for the first time that there's a decline in maternal mortality. Now, I want you to contrast that with global maternal mortality. I know I started with the US maternal mortality, but if you look at those numbers compared to global maternal mortality in other parts of the world, you can see that the mortality rates are exponentially higher, particularly in West Africa, compared to countries like the United States. In Nigeria, for example, this is based on the WHO data that was published in 2023, and it's using data from 2020. It estimated there were approximately 82,000 maternal deaths in Nigeria, and that's the highest absolute number that was reported in a single country in that year. And this accounted for about 28.5% of global maternal deaths. So clearly, maternal mortality in Nigeria is a significant global health crisis. I also wanted to put in some statistics that I felt were particularly sobering for me when they estimated the lifetime risk of dying during pregnancy or following childbirth for a 15-year-old girl. You see that number is 1 in 19 in Nigeria, and it's as high as 1 in 15 for a girl growing up in Chad. Also, estimates are showing that maternal deaths are mostly preventable, and we can do something about this. While there are multiple reasons why we see maternal mortality, there are specific areas that we identify significant unmet needs. And the one I'll be focusing on is cardiomyopathy specifically. So pregnancy-related cardiomyopathy, and now going back to US data, is a leading cause of maternal death, particularly when we start to look at that late postpartum period, which is 6 weeks following childbirth through 12 months. Cardiomyopathy is actually the #1 cause of death. Again, when you think about cardiomyopathy, when it occurs and the likelihood of dying, this disproportionately again affects Black women who have a 5-fold higher risk of dying once diagnosed with cardiomyopathy, either during pregnancy or postpartum. A big challenge with identifying or recognizing cardiomyopathy during pregnancy is the fact that a lot of the symptoms of cardiomyopathy or heart failure overlaps with what we consider normal pregnancy symptoms due to physiologic changes of pregnancy. So it's not unusual if a pregnant woman has lower extremity swelling or reports shortness of breath with minimal exertion, or even shortness of breath while laying in the bed at night due to the gravid belly. So how can we quickly recognize when a pregnant woman or a recently postpartum woman has heart failure symptoms? It tends to be tough. And when women report the symptoms, it could be dismissed as normal pregnancy symptoms. There's studies that are already being published as far back as the 70s that shows that, dyspnea is very common in pregnancy. Up to 80% of women who are pregnant will report dyspnea. So in Nigeria specifically, when we start to look at cardiomyopathy or pregnancy-related cardiomyopathy, they have the highest reported incidence globally, estimated to be as high as 1 in 100 live births, particularly in the northern part of the country. And mortality is also very high in Nigeria following the diagnosis of cardiomyopathy, ranging from 19 to as high as 41%. Again, the challenge is quickly recognizing the condition, the fact that there is no single screening test, there's limited access to echocardiograms, and then high out-of-pocket cost for healthcare in general is an issue in Nigeria. I mentioned the concerns with quickly identifying the diagnosis, and I have also described earlier how normal pregnancy symptoms overlaps with heart failure. But there's also another big challenge in Nigeria, which is the availability of specialized care. Diagnostic testing is limited in certain areas and can also be expensive. Also, cardiologists, few in the country estimated, and this was a 2023 estimate, that there are approximately 450 trained and licensed cardiologists for a population of over 200 million in Nigeria. So now let's talk about what do we currently do, and this is the US screening recommendations for identifying cardiac disease in pregnancy, and cardiomyopathy or heart failure is one of them. I just shared this not because I want to go through it, but just to show you how complicated this algorithm is, of which the algorithm also leans heavily on symptoms, which we've already said can be a challenge in pregnant and postpartum women. So it is possible that despite the fact that this algorithm is available, apart from the fact that it's complicated, we might be missing some cases of cardiomyopathy that might be contributing to delays. I should also mention that this algorithm was developed based on data from 64 patients, and this was done retrospectively. Was a review of maternal mortality cases from California that was due to cardiac conditions, and that's how this algorithm was developed. It was initially published in 2017, and other than that, we don't have anything else for screening pregnant women. So huge gap, huge unmet need here. So the question we had that led us to the study that we designed was, can we leverage novel artificial intelligence technology, given all of the changes recently with new data and publications showing really strong and, remarkable performance of these models? Can we leverage this to address this diagnostic challenge in pregnant and postpartum women? Which leads me to talking about the AI-enabled ECGs. So, an AI model that is based on 12-lead ECG data was developed at Mayo Clinic, and the first paper was originally published back in 2019, demonstrating that you can take data from a 12-lead ECG and predict the likelihood of a low ejection fraction, which really is one of the cardinal things we're looking for when it comes to peripartum cardiomyopathy, which is a unique form of cardiomyopathy that occurs towards the end of pregnancy and postpartum. And one of the key diagnostic metrics is an ejection fraction less than 45%. So this particular model was developed based on retrospective data, and multiple other studies have been done since then, including validation studies in external patient populations, as well as prospective studies and a clinical trial that was done in a primary care patient population. So one of the first steps we did was, can we retrospectively evaluate this model in a cohort of pregnant and postpartum women? So we did that initially using data from Mayo Clinic across all of our sites and demonstrated really strong performance of this model. So once you do something retrospectively, one of the next steps is, prospectively, does this work? Is it possible that this retrospective sample of patients were just higher risk patients because they had already been referred for echocardiograms? How about if you took all comers that you were seeing in an OB setting? So we designed a pilot study that was done in the US, and we enrolled 100 women consecutively that were seen across 2 Mayo Clinic sites, and we also partnered with a federally qualified healthcare center in downtown Jacksonville. We ended up with 100 women in that study, and 6 of them had cardiomyopathy. So in that study, the way it was designed, because it was a pilot, we would screen the women, have them do the ECGs, and we recorded not just standard 12-lead ECGs, but we also recorded portable ECGs. And on the same day, they got an echocardiogram as well, so that we could correlate the AI predictions from the ECG with their echo results. And I just wanted to show you just a quick example from that pilot study, what we saw. The ECG on the left was belonging to a patient that had a low ejection fraction, and the one on the right with normal ejection fraction. While the one on the left had some subtle ECG changes, it really was interpreted as a normal ECG, and this was read by a cardiac electrophysiologist. So just showing that sometimes some of these changes on the ECG might not be readily apparent for us to tell that this patient might be high risk for having cardiomyopathy, and that the AI interpretation really adds something extra to this, to the diagnosis of cardiomyopathy. So in the pilot study, we also evaluated a portable device that is able to record a single lead ECG as well as the heart sounds, as we started to think about potential scalability and doing this in a place like Nigeria. The model that was developed using the 12-lead ECG data had been modified to work with single-lead ECGs and was licensed to the company that manufactures this digital stethoscope, so it could be deployed in that format. Also, the nice thing about using a portable device is the fact that the AI predictions were also available to the provider in real time. So once they recorded the ECG, a 15-second recording, it's connected to a smartphone, and the AI predictions will be available right there at the point of care. They didn't have to upload the ECG somewhere, wait for some time to get the results back. And this was really critical for us in designing a study in a different part of the world where there are challenges with getting patients to come back for care. So the results of the pilot study that was done in the US was really very reassuring about the performance of the AI ECG. For the 12-lead ECG results, I didn't put that on the slide. It actually had perfect discrimination with an AUC of 1. Sensitivity and specificity were 100%. The results for the digital stethoscope is what I'm showing on the screen with AUC of 0.98 to 0.97, depending on the ejection fraction threshold that we were using. But also, same thing, had a sensitivity of 100% for EF less than 50% and EF less than 45%. But remember, the caveat is this is a small study, 100 patients with only 6 with cardiomyopathy. So this led us to designing the clinical trial, which was done in Nigeria, which I'll be spending the rest of the presentation talking about. So the results of that trial was published in Nature Medicine in August of 2024. And I'll jump into the methods really quickly. So there was another manuscript that was published just talking about the methods and how we designed the trial. And that's what the QR code is, linking you to that paper that talks about the rationale and design for this trial. So this was an investigator-initiated study. I've given you the background of why we thought that this was important, and we thought that this could make a huge difference in a place like Nigeria. Our goal was to evaluate the impact of this AI screening intervention on the identification of cardiomyopathy or LV dysfunction in pregnant and postpartum women. So in this trial, women were randomized in a one-to-one fashion, and we used a web-based application, and they were assigned to the intervention arm where they had AI-guided ECG screening, and the results of whether or not cardiomyopathy was present was provided to the physician. And I'll talk a little bit more about how this was done. In the control arm, however, we wanted them to receive usual care, but this was designed to be an attention control arm. So the control arm didn't just receive usual care, they also had standard clinical ECGs performed. And we also provided them with AI predictions for age and sex, which did not have anything to do with cardiomyopathy, so that our goal was to try and isolate the independent effect of that AI prediction specifically for cardiomyopathy. So in the study, apart from obtaining 12-lead ECGs, it was important for us to incorporate the digital stethoscope as well, because we were interested in evaluating something that would be relatively cost-effective and scalable. Another nice thing about this intervention is that the stethoscope is battery operated. It's portable. It can be moved around in different clinical settings compared to a standard 12-lead ECG machine that could still be a little bit clunky, requires some skill to perform because there are 12 leads. Sometimes the patients have to undress for you to be able to place the leads properly. But for the digital stethoscope, this can be done even while the patient is still dressed, while they're sitting in the waiting room, having their vital signs done, takes 15 seconds. And just, was a way for us to deploy something really rapidly in a different environment. So in the study, they got both the 12-lead ECGs as well as the digital stethoscope recording. We only had 2 recordings on the chest, and then we also had a handheld position. Now, this slide is essentially showing you how the study was designed, what the control group got, which is a 12-lead ECG with usual care. And the intervention arm had the 12-lead ECG, but they also had the digital stethoscope because that was able to provide them with the cardiomyopathy prediction in real time. So as soon as they were randomized, our goal was to get them for at least 3 visits during pregnancy and up to 4 visits in the postpartum period. but we also allowed women to enter the study at any time point. So only a woman who enters the study, say in her first trimester, will have up to 10 visits before the study end. But if a woman enters the study, say postpartum, she would ideally not have more than 4 visits before the study ends. So we wanted there to be multiple time points so that we're able to detect cardiomyopathy if it occurs at various time points, because this is anticipated in many of these women to be a de novo diagnosis, particularly if this is peripartum cardiomyopathy. The study was not designed, however, to distinguish between de novo occurrence of cardiomyopathy and someone who had pre-existing cardiomyopathy prior to pregnancy, because we were not screening the women prior to pregnancy, so they were already pregnant. Our goal was to capture any form of cardiomyopathy if it was present in this woman during her pregnancy or within 12 months postpartum. So for our study analysis, we plan to use a modified intention to treat analysis, and we only included participants in the final analysis who completed the baseline assessments. This was really important because if a woman agrees to or consents to participate but never has any of the ECGs done, then it was very hard for us to analyze, whether or not she got an outcome or the outcome of interest. So unfortunately, there were some women that at the time that they consented, but before their test could be scheduled, we had some women pass away because of how high maternal mortality is in the country. And then for some of them, they were lost to follow up. And I'll show you kind of a flow diagram. Our primary endpoint really was identification of any left ventricular systolic dysfunction during the study period. For our secondary endpoints, we wanted to evaluate different ejection fraction thresholds. So primary endpoint focused on EF less than 50%, and then we looked at all the different other thresholds which all have clinical relevance. And then we also looked at some specific subgroup analysis based on age, hypertensive disorders of pregnancy, and composite cardiovascular outcomes. So we had a total of 6 participating sites in this clinical trial. 2 were in the north. The northern part of the country has the highest reported incidence rate of peripartum cardiomyopathy, and then we had 4 sites in the south, with each site enrolling approximately 200 women, and you can see the final number from each of the sites is displayed on the screen. So we ended up with 1,232 women who consented to participate in the study, and this were randomized to 616 in the intervention arm and 616 in the control arm. And you can see the various reasons why women were excluded before the analysis. 2 of them were not eligible due to, one, because she was too young, was 16, the other one because she had already participated previously. And then an echocardiogram was not completed in some of them, and all of the different reasons are shown on the screen. I also wanted to mention that we enrolled participants starting in August of 2022 through September of 2023. So approximately 12 months, we were able to get 1,200 women enrolled in the study. And then we followed them up through May of 2024 for a total of approximately 8 months active study period. So in our final analysis, the final number following exclusions for those who did not complete their baseline assessments was 1,195 women. The median age of participants was 31. At study entry, 73% of the women were pregnant and 27% postpartum. And for our primary endpoint, we demonstrated that the AI screening using the digital stethoscope, providing the real-time AI predictions, doubled the number of cardiomyopathy cases that were detected in the intervention arm compared to the control arm, with an odds ratio of 2.12. We also calculated the number needed to screen using this technology, and that number was 47. This next slide essentially just summarizes the results of the trial, just in graphic form, showing that we doubled the number of cases by screening compared to usual care. And this was not just usual care, this was an attention control arm that also had a 12-lead ECG provided, and the clinical results provided to the managing physician as well. So I want to talk a little bit about some of the important secondary endpoints, which is model performance. Even though this was a clinical trial that was designed to evaluate the impact of the technology on diagnosis, whether we would increase the diagnosis of LVSD or not. We also wanted to use this as an opportunity to validate the technology in a different patient population because this tool was developed in the United States and now we're deploying it in Nigeria and Africa, which was a predominantly Black patient population. So all of the patients in the intervention arm, for us to validate the technology, we had echocardiograms performed at baseline as well. And for any change in the AI prediction, then they had a repeat echocardiogram as well. So this allowed us to generate the performance characteristics of the AI technology, but only in the intervention arm, we also had paired echocardiograms. So for performance of the digital stethoscope for all the different thresholds is what I'm showing on the screen for less than 45%, less than 40%, and less than or equal to 35%. All of this is relevant for different reasons. So for the threshold less than or equal to 35%, this was the original training endpoint for the Mayo Clinic algorithm when it was first developed, because the goal was to detect severe forms of cardiomyopathy. Following that initial development, the model was refined, and the version of it that actually has FDA clearance right now was for detection of an ejection fraction less than 40%. So now less than 45% was clinically relevant to us because that is the threshold at which we make a diagnosis of peripartum cardiomyopathy. So by looking across all of these various thresholds, you can see that the performance of the algorithm was pretty strong, whether using the digital stethoscope or using the 12-lead ECG. I should mention that the teams were also provided with the AI predictions for cardiomyopathy for the 12-lead ECG, but this was done asynchronously. So sometimes it will take a couple days for them to get the results back because what happened is once they do the ECG, they have to download it, then they have to upload it to a secure link, and then study team members have to download these, run the AI algorithms, and then communicate this back to the team. So that took a while for them to get the predictions back, and it usually was not available at the time that they were seeing the patient. And I've already emphasized all the different reasons. So now looking at some of the other endpoints, looking at composite adverse outcomes, adverse cardiovascular events, preeclampsia, and several of the other things we looked at were very similar across the intervention and the control arm with no significant differences. However, all-cause mortality was particularly different, and this was significant. As you see in the intervention arm, we recorded more deaths compared to the control arm. And this actually raised a lot of questions. If we're screening and identifying these women earlier, why the women dying more in the intervention arm than the control arm? And this was something that was also challenging for us to explain. But just remembering the way that our study was designed, the intervention arm actually had a lot of follow-up. They had baseline echocardiograms. They came back for repeat echocardiograms anytime their AI predictions were different. So they were very much plugged in with the cardiovascular team as opposed to the control arm that saw their OB. They weren't having any AI predictions and received usual care. They had their 12-lead ECGs done at study entry, and that was about as much follow-up as they had. They had serial ECGs if they came back, but we weren't providing AI predictions for cardiomyopathy. So one of the thoughts was that it was the group, the intervention arm, we were better able to closely follow them up and ascertain their clinical outcomes compared to the control arm. I should also mention that in Nigeria, there is no national death registry. So tracking mortality was actually very challenging. A lot of the hospitals still use paper records. And sometimes once the women deliver, they don't come back to the hospital. So we had to track them down by calling the patients or calling their relatives. And there's a lot of cultural issues surrounding that as well, providing what they consider to be private information over the phone was something that many people or many of the participants did not feel comfortable with. even for the women in the intervention arm, sometimes for us to ascertain mortality, this was through the cardiovascular teams because they had a relationship with them. So sometimes when our study coordinators will call to ask how the woman is doing, they just say they're fine. But then when we had conversations with the cardiology team, they'll be like, oh no, she passed away, but they won't tell you that over the phone. So a lot of challenges with ascertaining mortality in this study could have explained why we see this difference. So just to summarize the study, we did see that there was a differential impact in the performance of the AI algorithm. So remember, I emphasized a lot that the digital stethoscope, the results were available in real time, and it was the results of the digital stethoscope that I presented, which was that odds ratio. We also analyzed, the performance of the 12-lead ECG, which we provided them with the results much later on. And while that showed that there was an increase in the detection of cases, that actually did not meet statistical significance. The odds ratio was about 1.75. And we realized that the sensitivity of the 12-lead ECG algorithm was actually lower than the sensitivity of the digital stethoscope algorithm because we're using the same thresholds on how it was trained and deployed in the US, and this was not modified for the population in Nigeria. So we felt that this study really opened our eyes to some of the variations in diagnostic performance metrics based on pre-selected thresholds at model derivation. And in this case, sensitivity was the issue. We also observed higher all-cause mortality in the screening arm, and I've already kind of spent some time explaining that. Now, this is kind of my last slide talking about the study. I wanted to just talk a little bit about some of the implementation lessons that we learned. Huge or three broad areas was technical barriers when it came to actually deploying the intervention in Nigeria. We had challenges with like hardware for the 12-lead ECG machines. Voltage requirements in Nigeria was different than in the United States, and this equipment were purchased in the US. So we had, issues where the machines would have to be repaired or they would have to have maintenance while they were in country. And this was only a 12-month study. So a lot of the troubleshooting was also challenging because the local offices for the manufacturers of the device could not assist because these machines were purchased elsewhere. Also, a lot of the softwares that we needed to get the digital stethoscope to function could actually not be downloaded from the App Store in Nigeria, which was like shocking to us when we got there. So we had to find ways around things like this. So we had to purchase iPads here in the United States, where we pre-downloaded the apps and then shipped them to Nigeria. Although now all of that has been resolved and all of these apps are now available in Nigeria, but just talking about some of the challenges with doing this. A lot of health system failures I alluded to earlier, paper records, having to find the information that we need. Sometimes it was very challenging for women to come back for an echocardiogram even after their AI predictions change. We have to schedule it. If they come back, power failure, they couldn't get an echo done. And, financial barriers as well for this women for the multiple visits and transportation having to come back to the hospital. So I'm just going to skip over the last few slides. I wanted to mention that since that study was completed, both algorithms have since received FDA clearance, the digital stethoscope as well as the 12-lead ECG. Also, the digital stethoscope kind of has like a new improvement since that time as well. It's now able to acquire three lead ECGs as opposed to a single lead ECGs, and additional algorithms are also available at the point of care as well. And one of the other things that we are exploring moving forward, given a lot of the challenges we had with standard echocardiograms, is potentially incorporating like a point of care ultrasound for quick diagnosis among the women who screen positive so that this is a more actionable in terms of therapeutic interventions for the provider. And I will stop there. I know I'm 2 minutes over time and say thank you so much for listening.
Great, thank you so much. That was just really impressive and a lot of information. So I'm going to turn it over to David and just ask him to give us some comments and thoughts on the work and what we've heard.
Yeah, Demi, fantastic presentation. It's definitely an incredible power force kind of a body of work that really goes, from it really shows kind of Mayo Clinic's investment in this area that goes all the way from algorithm development to prospective clinical trialing. I think the work that Demi has done has really shown generalizability of a lot of the algorithm that's been developed because the context is that outside of this trial is that in the United States, in a pragmatic kind of prospective evaluation, the Mayo Clinic and investigators at, I believe, in the Rochester campus actually shown validation for similar works in a cluster randomized clinical trial. It's definitely much more work to do this prospectively in a foreign country and in a very different site with obviously very different demographics and in a population that is kind of in many ways more sick, harder to ascertain outcomes and to evaluate and use the algorithms. I have a couple of questions. So on a great way, would love to kind of learn a little bit from the great work that Demi's done. And I think a lot of it, Demi, is like you've highlighted a lot of issues in kind of that translation across sites, across patient populations and such. How often were you going to Nigeria, or were there team members, or how did that work, or how did you troubleshoot some of these things, particularly with the app and stuff like that?
So one slide that I think I forgot to include, trying to shorten my slide, is a list of acknowledgments of the people that made this possible. And I have to say that we really leaned heavily a lot on the in-country Nigeria team, who were really motivated to actually get this study done. So I did go to Nigeria twice. I did go for like a kind of like a site initiation visit, and I visited all of the sites and met with all of the investigators. And then we just stayed in touch during the study. Also, this was kind of like towards the end of the pandemic. There was still a lot of masking, and there were a lot of challenges with that as well. So we stayed in touch. We had weekly meetings with all of the study coordinators from all of the sites. We had a lead study coordinator that would check in with all of the other coordinators. And then for the site PIs, we made sure that there were two PIs at each site, a cardiologist as well as an obstetrician, because that really helped with workflows, getting echoes and things like that, and recruiting from the OB clinics. We met with them every month via Zoom as well, and they were all very engaged. I think one positive thing that I didn't mention about this study is, like, people always ask, like, how often were women willing to participate at this? We had actually very high engagement. In one of the site, 100% of the women who were approached to participate agreed to participate in the study. Very few sites had women not want to participate, and it wasn't really because they didn't want to, it was maybe the challenges related to coming back. So surprisingly, the population as well as the physicians and the staff were actually open to a new technology. There was, should I say, less skepticism. There were some that were skeptical, well, this was developed in the US, but they were still willing to try it out. Even a lot of the staff, like the nurses, were like, well, can I get screened too? Wanted to be a part of this study, which was, I think, really contributed to the success of the study. But really, this was driven by the in-country staff on ground.
Hmm. And Demi, one of your, I think, main points, and oftentimes something to consider in the implementation of AI is like, what's next after this RCT, right? I can imagine the devices are already in country. The teams already know how to do it. Is this kind of standard of care in Nigeria now, or are they actively using it, or are you planning to kind of evaluate its performance in a prospective cohort, or kind of what's next, or what does it look like on the ground now?
So that's an excellent question, and really is something that we are also hoping to move forward. So one of the next steps for us right now is actually implementing it, because implementing something in the context of a clinical trial is very different than day-to-day clinical activities. So, there's a lot of resources to support a clinical trial when you say come back for this number of echocardiograms, which I already told you the challenges with that. So one of the things we realized is that if this is going to be rolled out, there needs to be easier access to echocardiograms, which there isn't currently. And that's why I kind of like put that slide at the end, is one of the things we're thinking about is this maybe should ideally be paired with a handheld point of care ultrasound so that they can get those results a little bit faster. And now we're thinking about pairing it with another AI technology, because think about it, availability of sonographers is almost zero. Only one of the sites had a sonographer that could get echoes. All of them had to be done by cardiologists, and they're few and far between, which is also a challenge. So we're thinking about AI guided point of care acquisition of echocardiograms as well. well as automated provision of ejection fraction right there, which you are very familiar with because that is a lot of your work as well. So we are thinking about designing an implementation study that would let us do this, as well as, do some task shifting. The providers are also very busy. Can we have the nurse who's doing vital signs do the digital stethoscope? It doesn't require a lot of skill to perform. And then that way they are risk stratified, and only those who screen positive will go ahead to have the point of care ultrasound. Can the person who is seeing the patient getting an OB ultrasound do that? And then before they are being referred to a cardiologist, because there are very few of them available as well. So we think we need to work out the actual implementation kinks by designing a study that allows us to answer that. And then we have a way for us to roll this out into different clinics. But we're excited about, the possibility of doing this. There's also the challenges with getting funding to do this from a global health standpoint, which is also another challenging discussion at this time point.
And I think in the interest of time, so I'll ask one last question and I think turn it over to Vinny, or Vinny, let me know if you want me to ask the questions in the chat. But the general question is, definitely it always requires a little bit more work to think about what is the downstream outcome. It's one of the things where I think that you've shown this algorithm works very well at a variety of thresholds and in different essentially kind of ways to implement it. Do you have let's say, the downstream reflex kind of treatment and evaluation is done, but is there a best way per se? Is it the V2 position at an EF of 45, or if ultimately kind of patients and clinicians need a yes, no, they need an echo, how do you decide kind of which of those thresholds or which of those algorithms you trust?
So that's actually a great question. And we actually had the opportunity to evaluate this in the pilot, as well as other studies that were done outside of the pregnant patient population. So talking about the position of the digital stethoscope, the single location that had the best performance, and it didn't have the best performance across all of the threshold, but optimal when you're thinking about sensitivity, specificity, MPV, and PPV was at the angled position. And that really correlates with, now that there's a new design for the stethoscope, the Core 500, with placing it over the left upper sternal border. If you're recording that single location, had the best performance. So just thinking about, being able to roll this out rapidly, what we're thinking is that, is a single recording sufficient, or do you have to do all four? Yes, a single recording is sufficient, left upper sternal border or angled if you're using the old technology. So just thinking about how to roll it out. I feel like I forgot the other things you asked apart from the location of the stethoscope.
Perfect. Vinny, I'll turn it over to you. Do you want me to
Yeah.
ask the questions? Okay.
No, I mean, I think some of the questions in the chat are related to topics you've brought up, which are, thinking about public health system implementation, and then how do you apply the learnings at scale. I mean, I think this is just such an interesting study, and let me just, because I'm naive in this space, is there a study of this type that's already been done, let's say in the US population?
Not in pregnant and postpartum women that I'm
Okay.
aware of, prospectively, no.
So you've advanced, so you put us in a very challenging position, which we're not often in, which is the evidence base is strong in this resource limited setting. And so the question immediately becomes, I think, just like, let's put the global, health aspect aside, but even for AI implementation in the US, this kind of concept that is the evidence base strong enough to implement, I think, what sounds like a pretty lightweight, relatively potentially low cost. I think, if you, I bet you if you gamed out the numbers with your number needed to screen and the cost of proactive preventive care in peripartum cardiomyopathy against the cost of the intervention itself, you'd very rapidly reach a cost effectiveness number that feels appropriate. But is that evidence base strong enough to deploy such a thing in the US, where some of those challenges related to, the app interface and, the voltage, lack of discordance or whatever, like, how are you thinking about that? Because it's so interesting that you've established the strongest evidence in Nigeria, and that has this kind of paradoxical impact on the US here.
And I want to say I completely agree with you, Vinny. And I think that yes, we absolutely need a study here in the US. In my mind, the evidence is strong enough, but as you can imagine, we need to be able to provide that same level of evidence here in the US. Usually, for it to get into the guidelines, it tends to be a little bit challenging once the studies are not done in a setting that is considered comparable. Also, prevalence rates really impact the performance of a lot of this diagnostic or screening tools, right? And in the United States, the prevalence is estimated to be about 1 in 2,000, even though I think that that number might not be quite right because we don't routinely screen pregnant women. And some of these women may be asymptomatic as well, which is another question that I feel we can answer if we designed a study to screen all comers, but we'll have a better idea. Do we just miss more cases? How often do we see LV dysfunction in pregnancy? We do not know the answer to that. So yes, we do need a study to look at that. It will be fairly, like you said, low impact, probably fairly easy to design, but expensive because doing a study in the United States, what really costs a lot of money is the staffing, then follow up. I mean, echocardiograms range from about $800 to $1,500, depending on where you are, just for an echocardiogram. And then, we need confirmation as well. So we've been thinking about, really, should I say more, smart ways to deploy this. Do we deploy this, screen with a stethoscope, and then just do a point of care ultrasound, given that we have access to a lot of echo-based algorithms here to save us cost on that standpoint? And then do we screen a higher risk population so that we can get more rather than waiting for 1 in 2,000, which means you need to screen a larger number of women? Or do we screen all comers, make it easy, and only filter down those who screen positive to additional testing? But then you lose a lot of diagnostic performance metrics by only screening those who screen positive, right? Because what about the false negatives? So a lot of different things that we've thought about, and we've submitted a couple NIH grants as well. We're hoping that one of them will pan out and we'll actually be able to do this study here in the US.
Yeah, I mean it sounds like the evidence base is super strong. And if you took your performance metrics in Nigeria and applied them to the US, and knowing that, kind of probably underreported incidence rate of cardiomyopathy, I think the cost effective numbers would be their ICER, your incremental cost effectiveness ratio would be super favorable. I think. What's so interesting here is that you could think of a strategy like a lower cost strategy that would just use the ECG, right? Because even though it was half as good, I think, if I'm interpreting the results at identifying cardiomyopathy, it still showed extremely high discrimination
Very much.
for reduced EF. And so, on a cost basis, much lower cost intervention, but still would enhance our capabilities from where we are today. What do you think about that?
So that's a good point. And as we are thinking about designing the study, our hope is that we will be able to gather relevant data from both sources. So we did a pilot study here, remember, in 100 women. And one of the concerns that we picked up was that OBs are not comfortable with getting a 12-lead ECG done in their clinic because they're like, who's going to interpret it? Who's going to look at it for me? And then they're calling the cardiologist and freaking about all the, T-wave changes. And, pregnant women may have some changes on their ECG. So, but they were more comfortable with the idea of a digital stethoscope because they're examining the patient. It just gives them the results. They don't have to worry about the downstream interpretation of a 12-lead ECG. So just, thinking about some of the things that we wouldn't worry about, maybe as cardiologists, but implementation really does become challenging when it comes to all of those things. What if they find something? What do they do about it? And what is the next steps? So, but I agree with you. In a setting like the US, a 12-lead ECG might be easier or cheaper, less expensive, but it just becomes complicated. Also, 12-lead ECGs are not readily available in OB clinics. They are in cardiology clinics, but not in the OB clinics. So I have to send them elsewhere or to the hospital to go get the ECG done. So this means you're buying machines to put in the OB clinics as well. And just thinking about, well, what else would they use it for? So multiple different things that we really have to think about as we design what is the best way to deploy this. But I hear you. I think that there might be a need to also adjust the thresholds that we are using currently, even for the 12-lead ECG, because remember, the performance was great. The AUC was like 0.94, but the sensitivity is based on the threshold we're using. And we've already seen that in other studies that when you do subgroup analysis in younger patient population, the sensitivity is poorer. So it's better because a lot of the studies were done in middle-aged patient populations, not looking at young people that don't have comorbid conditions. So I do think if that threshold was different for younger people, the 12-lead ECG will work just as well. We just need to get that threshold correct.
Demi, that's an interesting question. My understanding is that the FDA, or during the FDA submission process, you define the threshold. It's a little bit, they don't like you to post hoc cherry pick what looks best. Does that mean for these algorithms they need new approval in this use case? Because theoretically, you can say LVSD is a superset of kind of peripartum cardiomyopathy, and it should work in that space, or it's cleared for that indication already, or how do you think about that?
So that's a good point. And you're right that yes, you have to set that threshold ahead of time. But then they also make you provide all of these tables, including age and subgroup analysis. And in one of the documents that was submitted to the FDA, people younger than 40, the performance characteristics were not as good as if you are 50 or older. So this is something that we already know. And I think that as we start to think about some of these algorithms moving forward, maybe we're going to be moving away from just like this binary cut points. Maybe we need to start thinking about thresholds for specific patient populations. Think about the way we use, BNP and how it's different depending on your age or whether or not you have AFib or, or D-dimer threshold values. I think that some of these things are going to become more important moving forward. There are also ways to update like the FDA approval process. There's things called this predetermined change control plan that you kind of say in advance some of the updates that you're going to be making to the algorithm, and then you can make those updates without having to submit a new application. But if you do make significant changes to the interpretation, then yes, this might mean getting a new approval specifically for pregnant and postpartum women.
Yeah. Tommy has a question, which I'll summarize as, it seems to me like the manufacturer of that stethoscope, Echo, I think it was Echo, would be very, very interested in building the evidence base for kind of what you've done. How are you thinking about, and how should we think about, that as a kind of like a sponsored trial, similar to what happens in pharmaceuticals?
So completely agree with you. And we would love to have one of these companies sponsor a trial. But like we all know, trials are very expensive. A lot of the companies that are in this space are young, new companies that really cannot afford, the amount that a drug company like Pfizer will be able to pay for a study. So I wonder if we need to start thinking, about opportunities to leverage this. And maybe it's not just the company, maybe it's just, technology-based companies in general, about how can we leverage some of those opportunities for funding to be able to support building a database, clinical trials moving forward. And I think we probably have to get creative too, just thinking about the climate that we're in, about other potential sources of funding. Some of the other things that have been introduced, like are if you're developing software or algorithms, sometimes people are able to get non-dilutive funding from like VC type organizations as well. Might actually be another opportunity to get funding to support things like this, but we're all learning.
Yeah, well, maybe that's an avenue of collaboration between your group and KP, even to talk about whether there is whether there is a pathway forward for a very pragmatic kind of embedded trial that would, minimize potentially some of the costs. And, obviously, again, the preventive care that could be applied by identifying these patients would have substantial, hopefully outcomes benefits, but also cost savings in terms of care. Of course, it'd be balanced out by, the cost of appropriate, research guardrails, as well as the technology itself. But I think there's a lot of potential there.
Absolutely.
Any other questions or comments from the audience? So maybe just digging in finally to a little bit of the detail. I don't know if I saw what the incidence rate was of cardiomyopathy or reduced EF in the population. I know there was like a 2x increase, but do you have a number, and how did that compare to US estimates?
So much higher than US estimates. So what we had before now was that the incidence was about 1%, which is that 1 in 100. And what we basically found in the course of the studies, we had about a 4% prevalence in the intervention arm because, we were able to essentially confirm every single case because they had echocardiograms. But that 4% prevalence that we had also comes with, potential things we have to think about, like the selection bias. These were teaching hospitals. So the 2 hospitals that we selected in the north are actually referral centers because they had echocardiograms, they had a cardiologist. We had to use a place where we had resources. So it's possible that that number may have been inflated for those reasons, but that's what we found in our study.
Were
Great.
these echoes read by Mayo cardiologists, or how did you adjudicate kind of how good the impressions are?
Great question. So it was a little bit challenging for us to like read all 1,200 echoes because this was also a study that had minimal funding, so and minimal staffing as well. So what we did was every single case that was positive, every single echocardiogram that was read as low EF, they were all transmitted to Mayo Clinic, and we overread those echoes as well. And for those that were read as normal, we selected a random sample of that was transmitted to Mayo Clinic from the sites that had the ability to transmit to us. One of the sites actually was very good. They sent us every single echocardiogram that they did, which was the site in Lagos, because they had a sonographer and they just had access to more resources. So we were able to review all of their echocardiograms, and we have those images too. I see there's one person in the audience that had their hand up. I don't know if we have time to take any other
Yep.
questions.
Just 1 minute, John.
Yeah. Oh, so this might not be a 1-minute question. Demilade, it's good to meet you
Same
virtually.
here.
And this is really exciting research. It really shows the transformative potential of AI-guided screening technologies in particular. And you probably can guess, I have kind of a big picture kind of question. What are the lessons learned? What are the wider implications of integrating these kind of AI-driven healthcare solutions in the public health system, or specifically, in relation to maternal health or cardiovascular health in resource-limited settings?
So I will try to answer that as quickly as I can. But, we all know that there are various ways to look at this about, potential risks as well as benefits. But I always think about it in terms of looking at the algorithm as like, what is the risk associated with deploying something like this? And I summarize that as if you get a false positive screen, you get an echocardiogram. If you get a false negative screen, it's kind of like no different from what you do in usual care. So the harm that you are introducing to the patient, I think, is so reasonable that this will be considered low-hanging fruit because you have a higher likelihood of identifying a patient that you would have missed anyway. There's that potential cost, the added cost of getting them to come back for an echocardiogram, which you may view as harm, but there's already been 2 papers published already looking at the cost effectiveness of AI ECG, particularly for detecting LV dysfunction, and it's been demonstrated to be cost effective. Another trial already showed that we do a better job with risk stratification when it comes to who do we send for echo when we do the screening first, as opposed to we just send everybody for echo if I feel like they need one. So there's all of that I think that there's much more to gain with a technology like this that may be different with other AI technologies.
Great, thanks.
Sure.
All right. Thank you, everyone. I think we are over time, but great presentation from Demi, and thank you so much for attending.